So in part two of the movement assessment lecture, we're going to start to talk about structural biomechanics. Structural biomechanics gets a fairly bad rap in this day and age. I think it's very overlooked. And I think because of, again, the prevalence of pain science and the disregard of biomechanics, we've actually stopped understanding bony structure, individual variations in people's skeletons. But we know that how someone is structured is going to change the way they move. So our skeleton is a constraint on our movement system. So we want to understand structural biomechanics because we want to know where someone takes load on their body, the constraints they have on their own movement, what they have to work around, and then also what is normal for them. So what's a movement pattern that we're not even going to try and change, because that's a normal strategy for the way that they are structured. So we're just going to go through different skeletal variations, not in depth. So these will just be touching on different variations, and it's just a broader overview of structure in terms of those kind of, I guess, abnormalities of structure from the foot up towards the spine. So podiatrists, again, will be more all over this one, but metatarsus adductus. So a lot of these different variations I learned from pediatric physio or developmental physio, where it's really important for them in those early years or early stages of infancy for the physios to be able to assess really well for these structural variations. And they take them very, very seriously, because they need to know whether they need to perform any corrective surgeries or whether they just need to monitor it as well. So the first one is metatarsus adductus. It's the most common foot deformity, more frequent in female, and for some reason more left than right. So with this, you'll see adduction of the forefoot with that convex kind of lateral border. So the metatarsus will be adducted inwards, convex lateral border, but the ankles will have normal motion. And often it's a result of the position of the baby during pregnancy, and whether that foot has just been squashed up into that position, it's developed into that metatarsus adductus. So next one, again, simple one, we'll keep it simple, which will be pes planus. So that really flat, what most of us would call kind of pronated foot, which is actually going to put more load kind of through tib post, or put some kind of stretch tension through there as well. And then we've got pes cavus, which is your high arched, really supinated, rigid sort of position. So pes planus, for me, I just look at that kind of where that navicular is sitting. Is that sort of sitting on the ground? Can they form an arch themselves? Or does it just stay in that flat sort of position? What's the calcaneus doing? Is it really everted? And just simple. So again, as physio, I'm not changing this too much, but I just want to be aware of kind of someone's structure. Are they really kind of rigid where they don't absorb shock? Are they really flat where they're absorbing too much shock and they can't get back out into that rigid lever? So that cavus foot, we'll see more rigidity. Sometimes I'll see sort of toe clawing with that as well. And then you just see that sort of stiffness through the longitudinal arch and maybe that transverse arch as well. But this can put excessive stress on metatarsals and maybe even calcaneus as well. They're generally not as good at absorbing that shock and adapting to different terrains, just because they're in that rigid sort of stiff high arch position as well. So then we've got tarsal coalition. Basically, this is a congenital fusion of two or more bones in the mid or hind foot. When kids are younger, usually that fusion is cartilaginous, so it allows enough functional motion. But then when they hit sort of teenagers, it starts to ossify, becomes kind of that complete bony fusion between the two bones. And that's when they'll start to lack that mobility, lose some of that range of motion as well. So when that hind foot motion is restricted, it places them at really greater risk of ankle sprain as well, because they don't have a few joints there that can move to dissipate some of the stress from a lateral ankle motion. That just goes straight on and they'll get into that real inverted position. So 45% talocalcaneal, 45% calcaneonavicular as well. So again, maybe the pods in the Q&A can fill us in a bit more, but generally with this, they might have that sort of flatter foot as well, and they might struggle to get up and supinate into a heel rise position as well. So again, we're not doing much about it, but we're always suspecting it in that kind of teenage kid with really stiff, maybe one side of their foot. Maybe we have a feel around and see if it feels like there's a loss of actual motion due to that bony block. So then we've got tibial torsion. So there's inwards or outwards rotation or torsion of the tibia. So it either causes more of that in-toeing position or that out-toeing position as well. Thigh foot angle. So I don't actually measure this too much myself. I just kind of want to know, generally does someone look like they've got a bit of rotation through their tibia? And over time, pattern recognition, you just start to see when you think someone's got a bit of, I'll often notice that external tibial torsion, that kind of toe out position. And sometimes it can, I think, just put more load through sort of tib ant. Usually they've got a hypertrophy tib ant as well. Might predispose them to compartment syndrome. So internal tibial torsion, it's not coming from the femur, it's from that torsion of the tibia. External is that toe out position. But it is pretty difficult to distinguish whether it's rotation from femur or acetabulum or tibia. Foot progression angle. So this is just that, we look at this in running as well. So they got that in-toeing or that kind of real out-toeing position as well. So in-toeing could be a whole lot of different things. It could be internal tibial torsion, that metatarsus adductus as well, particularly in young kids, or femoral anteversion. So they're kind of the areas where we're looking at someone's getting rotation from to promote that increased foot progression angle. Look at the knee valgus, so your knock knee position. Basically, it's a angulation of bone distal to the joint, so distal to the knees of the tibia, to away from the midline. So valgus is, I guess, abduction of the tibia in relation to where the knee is, so knock knee. And then we've got varus as well, which is angulation toward the midline of that tibia. So varus is just going to change where someone takes load. That varus position is going to load that medial knee over time, might end up with knee osteoarthritis. Valgus, we're meant to have a little bit of knee valgus. We talked about in that first kind of evolutionary biology lecture why we need that knee valgus position, but excessive can come from that, femoral torsion, femoral anteversion as well. So that knee valgus is just when someone's kind of standing feet together, other knees really far apart. So that's that kind of valgus position. It's actually son and father. His dad's more, sorry, the other one's varus here. And then knee valgus. So knock knee. So you can see the two different. So knees a lot closer than feet. Feet a lot closer than knees. Knee hyperextension. So this is just moving up the kinetic chain, just things to be aware of, bony structural changes that we can't change, but are going to dictate how someone moves or loads. So knee hyperextension. So this is when, you might lie someone down on the bed, you kind of gently block or hold the proximal tibia, grab underneath calcaneus and just feel how much knee extension they've got. So sometimes you might get about 5 degrees, but if someone's really up towards 20, really lax, they've got that hyperextension. Sometimes they're just hypermobile. It's often associated with that kind of sway back posture as well, that really loose ligaments that just hang off their ligaments. They're really kind of low tone, really lazy in their standing. They don't use kind of that active strategy, but it can stress the posterior capsular knee, and sometimes might be higher up the kinetic chain as well. So the knee extension is just balancing out where that center of mass is from maybe that sway back position higher up. So always kind of thinking about that too. Trochlear dysplasia, so moving towards the patella. That's just basically a flatter or maybe even convex trochlea where the patella sits. So if we think of recurrent patella dislocations, sometimes you have someone who just literally has a really poorly developed trochlea and they're just at risk of patellar instability. So again, we can't change it, but it's handy to kind of know that these things exist and they predispose people to these kind of injuries. They're going to need, lots of sort of quads control, whether quads can even control that. Sometimes they need kind of that surgery as well. So it basically just doesn't give them that normal bony constraint to provide stability around the patellofemoral joint. So then we've got the hip. So the mechanics of the hip are obviously dependent on relationship between femur, acetabulum. So anteversion. So I just think of anteversion, probably don't want to confuse it too much because even I get quite confused with it. So anteversion is just your hip internal rotation, and it can either come from angulation of the tibia. So the tibia can actually be rotated and twisted just developmentally, or the acetabulum is orientated in a different position. So it's either faces a bit more posterior, where the femoral head is in its normal position with the hip into internal rotation. So this anteversion is just someone with that real internally rotated knock-knee position, but it's a normal position for their hip, unfortunately, in some ways. So femoral neck anteversion is the angle between the femoral neck and the femoral shaft. So basically that would look more like you've got femoral neck, and then femoral shaft. So there's some twisting, rotating between here and here. That's what a normal femoral neck, femoral shaft angle should look like. Femoral retroversion is the other way. So again, pretty confusing, but if you just start to think of anteversion being more kind of knock-knee, retroversion being more toe out, that duck type position, that externally rotated position, whether it's coming from femur or acetabular position, I don't think we really need to know that. But it's just handy to know how someone's structure can cause some of their rotation, their movement patterns as well. But basically, it can really affect the biomechanics of the hip. So it'll change where someone takes load. It changes the moment arms of different muscles and joint loading as well. So Alison Grimaldi goes into really lots of detail on her website and has courses specifically in depth on the sort of real honed into the hip as well. So I won't go too much into it. Then we've got that retroversion, so externally rotated femur position. But just understanding this and being able to assess and look at someone and maybe even give them insight into, you know, why they've moved like that their whole life, why they've sat in that W position as a kid up until teenager, why they're so loose through the hips and flexible, why they've had ongoing hip or knee issues, really helps someone just to give them, you know, it's actually your structure and we can work around it, but this is normal for you as well. So assessing that femoral version improves understanding of the patient's bony risk profile as well, and where they take load. So hip anteversion should have excessive hip internal rotation. So often I actually assess this in face up, so on the back with hip in 90 degrees and rotate that way. Not sure why I do it, but it's just, it also gives me insight into FAI as well, whereas it won't give you insight into that fader position in prone. So hip internal rotation will be excessive, hip ER might be normal or maybe even a little bit reduced. Hip retroversion will be excessive hip external rotation and then normal or maybe reduced hip internal as well. So this is different to dysplasia, where dysplasia is just the undercoverage of the femoral head. They've just got heaps of motion both ways. It's actually excessive in one way and maybe normal or maybe even a bit reduced in the other rotation direction. Hip FAI, so we've gone from sort of foot to tibia to knee to femur to hip. So pincer, so this is over coverage of the femoral head by acetabulum. And then we've got cam, which is basically a bony prominence or a bump at the femoral head neck junction. And this changes the femoral head from spherical to aspherical. So it just isn't a circle anymore. Increase the risk of impinging into the labrum through here. So FAI is just so common and so easy to look out for as well. So just simply take someone up into hip flexion and then just test how much hip internal rotation they've got there. If it's different side to side, if there's pain, if it's a pinch, if it's less than usually around kind of 30 to 40 degrees hip internal rotation in 90 degrees flexion, then you look like, you know, they've got some reduced range, maybe some hip FAI. So that's a really important screen just to do that kind of fader or internal rotation range at 90 degrees to give someone insight into what their hip joint orientation or bony morphology might be like. And then you've got combined, so pincer and cam as well. So then we've got hip dysplasia. again, it's a big topic. It's not my actual complete expertise, but you can kind of tell when someone has that dysplasia. They're kind of hypermobile through the hips. They've got heaps of range. Basically, a normal hip acetabulum will cover about 75% of the femoral head. In dysplasia, there's massive undercoverage as well. So with our normal acetabulum, we have less cover anterior than posteriorly, and this allows us to have a heaps more hip flexion range than hip extension. But that dysplasia is a 3D structural deficiency of the acetabulum, and it might give rise to instability of the hips. There's just so much range, and it can cause pain and lots of issues. It's a real risk factor for degenerative hip OA, much higher in females, and maybe familial history, but it's probably more so the mechanical loading in utero. So that breech birth position where the baby's forced into hyper hip flexion. So much of this developmental skeletal biomechanics anatomy is just how we're loaded in those early either weeks of our not even life, but or how we loaded our body through the first few months of life or the first few years as well. So we actually adapt our skeleton. Obviously, some of it's genetic, some of it's familial, but so much of it is just the loads, the mechanical loading we place on the skeleton in those either early years or in utero as well. So if we move to the spine, so structural biomechanics that we want to be aware of, scoliosis. So quick to do a Adams forward bend test. So clamp someone's hands to get them to hold their hands, bend forward. You'll see a rib hump if scoliosis. So has a sensitivity of 84%, specificity of 93. So if it's a scoliosis that's going to be functionally impairing them potentially, you'll see it on this test. You'll see a rib hump on one side. So this is just such a good screen, especially in teenagers, maybe even females, before they've hit their growth spurt. Because if you see this, you probably want to talk about getting an x-ray for them to see what kind of Cobb angle they've got for their scoliosis as well. So Cobb angle is basically the angle between the vertebrae that's most inclined in one direction and then the vertebrae that is most inclined in the other direction. Then we draw perpendicular lines and then we get this kind of Cobb angle. So say here, this vertebrae, whatever that is, T2 is the most tilted that way, and then maybe L1 here is the most tilted that way. So draw a line there, perpendicular. What's this angle? It's called the Cobb angle. So obviously, the bigger the lateral deviation, the bigger the Cobb angle, the more serious, and that's that surgical threshold. So between 15 to 20 degrees, mild, 20 to 40 might be moderate. So this is kind of always changing, but this is kind of general. Above 40 degrees, severe surgical. So really important one to pick up in adolescents, but also if we have even fully grown adults, we can still see if they've got a scoliosis. It's handy to know. Often their scap will move a bit differently. They'll have less kind of shoulder range on that side, less thoracic rotation, thoracic extension as well. Moving towards the spine again, so structural abnormalities, deviations, ankylosing spondylitis, so pretty nasty one where it's that inflammatory kind of fusing of the spine that slowly progresses into real complete fusing. Cause a lot of pain. It's inflammatory pain, so it's usually pain at night. It's usually stiff first thing in the morning. Usually someone will say they're stiff. It takes them 2 hours to warm up. It's not just that 5-10 minutes of kind of lower back stiffness. Often starts in the SIJ, so they'll get that sacroiliitis, usually the first kind of signs, and the affected joints become progressively stiff. So this is the person you start to see really hunch and lose their posture over time. So they'll have reduced range of motion, and it's actually called bamboo spine. That might be an old school term, but yeah, their spine forms into that real kind of bamboo position. But even a forward bend test, I mean, this actually looks like me, so hopefully I'm not too fused through the lumbar spine. But basically, they won't have any flexion through a forward bend test, and they'll get it all from thoracic. You'll see a big kind of thoracic rib hump position. And that might indicate that, there's some decreased range into flexion through here. Could just be tight hamstrings, tight neurally, but this is good to see. If someone does have ankylosing spondylitis, it's good to see how restricted they are through here as well. But you can only really tell this through kind of inflammatory tests, blood tests, check HbA, I think it's called, markers. Then we've got Scheuermann's or Sherman's. So this is vertebral wedging. So instead of the kind of rectangular vertebrae, we actually have wedged vertebrae, characterized by 3 or more wedged vertebrae, and usually diagnosed in teens, where parents see that kind of hunchback appearance and they start to get worried, or the kid gets getting really sore. And an X-ray will often show that Scheuermann's. So it's the most common cause of that kyphosis, deformity. So it's not a kid that has poor posture and can correct it. It's a kid that just is super stiff and they just have that vertebral wedging. So we just have to work around that, unfortunately. And that's with all these structural biomechanics, just things that we have to work around. But if we as practitioners don't understand the person in front of us and what we have to work around for them, we're really putting them at a disservice and just not understanding them and not helping them understand their own body as well, and their own, not limitations, but how to work around and how to maximize their own movement strength around just the anatomy that they've got. So Sherman's, lots of knee flexion, so just not much range. No extension as well. Just stiff as a board through the spine. So if someone is that stiff and they're young and active, then we've got to start to think about their structure and not just, okay, your muscles are tight. So same sort of just stiffness, just not much range. You just see them move really tight, and it's not always painful, but there's just not range through mid-back. It's just not smooth. Pelvis doesn't move much as well. Lumbar spine doesn't either. Then we've got hypermobility. So it's just we've got a Bateman score. So there's 9 items, I think. So one of them will be getting the thumb to touch the forearm, hyperextend the elbow 15 degrees, taking the hands back and clasping them, hyperextending the knee, ankle range more than 45 degrees, getting the hands flat on the ground on forward bend, being able to externally rotate the hip. Can't remember exact degrees, but there's 9 items. And if someone scores more than 4, generally they're hypermobile. So it's just where's the cutoff between not hypermobile and hypermobile? But it's just handy to know. This might not change anything, but usually hypermobiles need lots of movement awareness. They often move excessively in some areas that are easy for them, and in other areas they might not have too much motion at all. So they might get heaps of extension through their lumbar spine. We need to bring awareness to that, get them into more kind of neutral, know where they are in space, strengthen good kind of neutral positions or through range as well. So if they've got a lot of range, they need a lot of muscle control to control that excessive range too. So hypermobile, so want to be kind of hands flat, huge knee to wall position as well. Go really well with strength and conditioning, but or even movement control to start, Pilates and awareness, but then strength and conditioning after that. But we have to be good at coaching them for form, because otherwise they've got a lot of ways that they can cheat and get around movement. So you have to be a bit more aware about not letting them kind of just go towards their passive kind of lockout positions. So a lot of this is just, again, stuff I've learned from pediatric physio, different peds physios, but those developmental, rotational deformities, I say, they're pretty interesting, and they do affect people through their whole life, their loading patterns as well. So again, we want to be aware of structure, and if you start to think from the foot up, you're not going to assess all these things in everyone, but it's worth understanding what different structural skeletal variations there are, so it can help people understand kind of their limitations and, as I said, maximize their own potential.